Hello, and welcome to Your Health Matters. My name is Dr. Peter Hogenkamp, and today we're going to be discussing the question that William Shakespeare posed over 500 years ago, and that is, to be or not to be? Well, maybe not exactly that same question, but a derivative of that question, and that derivative is to be or not to be on a statin medication. I think most of us in 2024 understand what I'm talking about. When I say a statin medication, there are a number of them. And statins are used to treat hypercholesterolemia or high blood cholesterol. High blood cholesterol, by simple definition, is too many fat-like particles in the blood, which causes your atherosclerosis, which is the lining of arteries with cholesterol, which takes a nice wide artery and makes it shrink down to that way, which increases your risk of a number of problems that we're going to talk about. Just to kind of give us a little sense of how big this problem is in our country and the world, 4 out of 10 people have, or 40%, have high cholesterol as adults, and that's 18 and over. So if you are 18 or over and living in the United States, then you have a 40% risk of having high cholesterol. So why is it bad to have high cholesterol? Well, I think most of us are aware that cholesterol is a major risk factor for cardiovascular disease. It's also a major risk factor for peripheral vascular disease, which is the narrowing of the arteries to the arteries in your legs, for instance, which can cause problems like pain in the legs, loss of limb, that kind of thing. It's a major risk factor for cerebral vascular disease or strokes and narrowing of the carotid arteries. It's a major risk factor for a number of other issues, including aneurysms, mesenteric vascular disease. We don't see these as often, but again, just to point out, it's not just heart attacks and strokes that are at risk, that we're at risk for here. So, how should you, as the viewer, start off by assessing your risk for cholesterol? And the first thing that we should do is get our cholesterol checked. It's amazing to me that in 2024, I still run into people routinely who haven't had their cholesterol checked in years. Some people never. Just so that we're aware, the guidelines for having your cholesterol checked are starting at age 20. I tend to start at age 11 in my practice. I'm a family doctor, so I see kids. So I tend to check cholesterol starting at age 11. And the reason for that is because if you take a look at people who have high cholesterol as adults and you follow their blood samples backwards in time, they'll have high cholesterol when they're much younger, all the way actually down to 2 years of age. So a lot of these folks, you can identify them very early on. And the earlier that we identify them, the more quickly that we can address the situation. And for these younger people, I'm obviously not talking about statin treatment. We generally don't start statin treatment until much later on. But we can get these people on healthier lifestyles, which, as we're going to discuss shortly, is very effective in treating your cholesterol and preventing cardiovascular risk. Remember now, the whole thing we're talking about here is preventing or lowering cardiovascular risk. Lowering your numbers is one thing, but the whole idea, what we're really trying to do, is to lower your cardiovascular risk. So, I just wanted to give you a couple more numbers. I'm trying to keep this talk low on the numbers because when you talk about cardiovascular disease, you can easily get into some math discussion that none of us want to be in. But just quickly, a few numbers. 4.4 million deaths per year, or 7.8% of all deaths in this country are related to high cholesterol, just to high cholesterol alone. 4.4 million or 7.8% deaths per year. So, how should you as a viewer start this kind of analysis? How should you say, all right, do I have high cholesterol, or you know that you have high cholesterol? The first thing you probably should do is just get it checked again. If you've got high cholesterol, we should be checking that annually. If you don't have high cholesterol, you should check it every 5 years until you're 50, and then every 2 years after that. But if you know that you have high cholesterol, this should be assessed every single year. So then the question becomes what to do about it. So you're a viewer and you know that you have high cholesterol and you're wondering what you should do about it. Well, I'm going to try to give you a very simple approach to this. And it's a very complicated matter when it comes down to looking at all the studies that we've done. Keep in mind now that cardiovascular disease is the #1 killer by far of Americans. As a consequence of that, it is also the most studied disease going. Obviously, if it continues to kill so many people, we're trying to prevent that. And so we're studying it. And I will say that over the last 20 years, actually longer than period than that, we have lowered cardiovascular risk in this country quite a bit, up until about 10 years ago. About 10 years ago, the drop in cardiovascular disease that we had affected actually stabilized, and cardiovascular risk is now actually been stable for about 10 years. And that's mostly due to the obesity and diabetic epidemics. We had been doing pretty good, and I think most of that had to do with treatment of cardiovascular risk factors, in particular cholesterol, in lowering people's risks. But in the last 10 years, just lifestyle issues in this country, as I mentioned, particularly diabetes and obesity, have meant that we've actually not had any further decreases in the risk of cardiovascular disease, which is very unfortunate. So I promised a simplified approach, and I'm going to give it to you. You get your cholesterol checked. Let's for this discussion, currently, we're going to say that you're 40 years old or up, and you get your cholesterol checked. Well, we break people up into two categories. Those with a bad cholesterol of 190 or above, and those with a bad cholesterol of 190 or below. This is by far the most important definition of high cholesterol. We used to talk about people with a total cholesterol of 200 or above, but since that, and we still use it just because historically it's been around and people like to hang on to it. But I don't find it that useful, nor do many other physicians. What is useful is measuring your LDL cholesterol or your bad cholesterol. We have the bad cholesterol or LDL and the good cholesterol or HDL. As an easy way of remembering which is which, I always tell people L for lousy cholesterol, H for happy cholesterol. It turns out that your levels of lousy cholesterol or LDL are directly related to your risk of having cardiovascular disease, because those molecules go out into your bloodstream and they coat the arteries in your body, narrowing them and damaging them. They inflame them. Not only do they narrow the artery, but there's inflammation that's caused there. There's weakening of the lining of the artery as well. All these things play a big part in your risk of cardiovascular disease. Happy cholesterol or HDL does the opposite. These are particles that are made by liver that go out into the bloodstream and actually remove the other cholesterol particles, bringing them back to the liver for processing. So you can think about this. I always tell people, imagine a roadway that you live on where people are driving by and throwing trash out. If you never pick up that trash, within a couple of years, there is going to be a significant amount of trash on the lining of that roadway. If, on the other hand, you've got a bunch of people like myself, I always love to pick up trash on the side of the roadways as I walk. I'm picking up that trash and putting it in a bag that I keep and then throwing it out. The roadway doesn't become littered with trash. And that's the same for arteries. The LDL goes out and deposits, makes fatty deposits in the lining of the artery, narrowing it, inflaming it, weakening it. And then the happy cholesterol comes by, picks it up, and brings those particles to processing. Therefore, it's important to know your ratio of cholesterol, and that is, what is the ratio of good to bad cholesterol? If you have high HDL, but also have HDL, you can still have an acceptable ratio and a much lower risk of cardiovascular disease. So what are the numbers we use? I'm not gonna discuss that because I want to keep this simple. I want to say if you have an LDL less than 190 or greater than 190, you have severe hyperlipidemia, and if you are 40 and above, the data clearly suggests that you should be on a statin medication. There's no doubt about it. So one hard and fast criteria for being on statin is LDL greater than 190. The only way you're going to know that is to get your cholesterol measured. And again, just in case you missed it, or in case you want me to reiterate it for effect, you should have your cholesterol checked every year if you have high cholesterol. If you don't, you should have it checked every 5 years if you're less than 50, and every 2 years after that, until you are 75. If you don't have high cholesterol, and if you've never had high cholesterol, at the age of 75, you should stop checking it. So let's go back to these hard and fast criteria for taking statin medications. We mentioned number one is an LDL greater than 190, which is the so-called severe hyperlipidemia. Number two would be anyone who has cardiovascular disease. So this is a very important point, so I'm going to mention it a couple of times. If you had a stroke, if you had a heart attack, if you had a stent placed, if you have angina, you should be on a cholesterol medication. There is no doubt about that. What I'm spending the bulk of my talk about today is for those people who don't have cardiovascular disease yet. So this is what we call primary prevention. We're taking people with high cholesterol and we're trying to prevent them from getting cardiovascular disease. If you already have cardiovascular disease and we're trying to prevent you from having having more cardiovascular disease, that's called secondary prevention. And we're not going to discuss that today, other than to say, if you have cardiovascular disease, you need to be on a statin. Number three, if you have diabetes, the evidence clearly states that you should be on a statin. We don't need to worry about anything else. So the three hard and fast criteria for being on a statin, to answer Willie Shakespeare's question, to be or not to be on a statin, are LDL greater than 190, known cardiovascular disease, 3, diabetes. So that is, those are the first three absolute criteria for being on a statin. So now let's go to the ones where they're not absolute, because this is the bulk of the viewers. It's you and I out there. So many of us have high cholesterol, but we're not in any one of those three categories. So these are the people that have intermediate risk. These are people who have high cholesterol, but less than 190. They don't have diabetes, they don't have known cardiovascular disease. And so these are the folks that we're trying to figure out whether or not they should be on a statin. That's the question that Willie posed, to be or not to be on a statin. It's for these intermediate risk people. So the first thing I wanted to mention to you is there is a wonderful tool out there called the Cardiovascular Risk Calculator. All you have to do is type Cardiovascular Risk Calculator into your browser, and it's going to pop up. The one that I like to use comes from the American College of Cardiology. It's right on there. It's free. All you do is type in your age and your parameters, such as your recent blood pressure, your cholesterol, whether you have diabetes or not, whether you smoke or not, and it gives you your risk, your 10-year risk for cardiovascular disease. Just so that you know, we divide this up into 4 categories. Low risk would be less than 5%, 10-year risk. Then there is a borderline of 5 to 7.5%, an intermediate of 7.5 to 10%, and then a high, which is greater than 10%. So if you're going to be in one of those 4 categories, I tend to lump it just into 3 categories: less than 5, 5 to 10. So I kind of lump the borderline and the intermediate categories together. I don't find it very useful to separate these. And then greater than 10% is going to be high risk. So I want to go through 2 hypothetical situations for you to kind of demonstrate people on opposite ends of the spectrum kind of thing. So we have a 40-year-old woman who has no family history of heart disease. She's not diabetic. She does not smoke. she's not overweight, she's active. She's what I call a lone hyperlipidemic. And by that I mean that she has no other risk factors for cardiovascular disease other than high cholesterol. Let's say her cholesterol is her LDL cholesterol is 150, so she's not in that greater than 190 category. This woman's risk is about 1%. Her 10-year cardiovascular risk is about 1%. What does that mean? That means she has a 1% chance of having a heart attack or a stroke or a stent placed in the next 10 years. It's very low. So would you place this person on a statin? And I personally would not. Why? Well, statins reduce the cardiovascular risk in everybody by 30%. Every single person that takes a statin, even if their cholesterol is low, even for people with low LDL, who don't have a cholesterol problem at all. If you put these people with low cholesterol on a statin, you're lowering their risk for heart disease even further. So why don't we just put statins in the water supply? Why aren't we dumping Lipitor or Mevacor or rosuvastatin or atorvastatin? Why aren't we dumping these things in the city water supply? Well, there's a reason for that. And that is this woman that we talked about, the 40-year-old female who's lone hyperlipidemic, has no other risk factors. She only has a 1% risk. If you lower that by 30%, you've lowered her risk from 1% to 0.7, which is not a worthwhile thing to do. So in other words, the benefit of a 0.3% risk reduction isn't worth the risk of taking a statin. Now, what is the risk of taking a statin? In reality, it's pretty low. I've been prescribing statins for my entire 30-year career, and I have had very, very, very few significant complications from statins. Now, we used to talk about liver problems. In my 30-year career, I've had one patient who had to stop a statin because it affected her liver. That's one out of thousands of people that I've placed on statin. One patient. What's interesting about this one particular patient is that she developed heart problems. So when I put her on the medication, her liver function tests went way out of sight. We had to stop the medication. They came down. There's no doubt. And that's the only time that's ever happened to me in my career. The interesting part about it is several years later, she developed a heart problem. And we put her on the cholesterol medication again, this time at a much lower dose, and she was able to tolerate the statin. So her liver function test only bumped up a little, and we were able to keep her on that statin. And to this date, she remains on the statin kind of thing, and has not had a secondary heart event since that period of time. There are people who do not tolerate statins, and these are people who get muscle aches from the statin. Now, the real incidence of statin intolerance is very low. The perceived incidence of statin intolerance is much higher. And what do I mean by that? Well, I put them on statin for primary prevention. In other words, they've got high cholesterol, but they don't have known cardiovascular disease. And they tell me, they come in 2 months, and I couldn't take that medication, my elbow hurt, or it caused my legs to hurt, or 99% of these people don't have real statin intolerance. But there are people that actually do have statin intolerance. I've got maybe 5 in my practice. And these are people that no matter what statin you put them on, or no matter what dose, they have severe myalgias or muscle aches. It does happen. It's very uncommon. Outside of that, there's very little risk to taking statins. But remember now, every time we do something in medicine, we want to do the risk-benefit ratio. That is, we want to say how much benefit do you get out of something, and then what is the risk of doing something. So in that woman who's 40 years of age, again, we are not going to put her on the medication because there's only a 0.3% risk reduction in her 10-year cardiovascular risk. Now let's go to the next patient. I called the first one a lone hyperlipidemic. This one I'm calling the walking cardiac time bomb. So the walking cardiac time bomb is a, let's say, 55-year-old patient who has poorly controlled diabetes. He has very high, let's say an LDL of 160, so high cholesterol without the cholesterol being above that 190 guideline that we talked about earlier. He smokes, he has a family history of cardiovascular disease, he's obese, he's inactive. And I have many of these patients. You're probably thinking I'm exaggerating, but I'm not. I have a lot of these patients. They walk in and I say to myself, how on earth is this person not hasn't had a heart attack? It's just impossible to me. They have every known risk factor, all poorly controlled. So when you put this person into the calculator, you're going to find that some of these people have risk of well over 50%. I've got a patient who has cardiovascular disease risk of 70%. This is a patient who I put their numbers into the calculator who doesn't have previously known cardiovascular disease, 70% 10-year risk. That's ultra high. So when you take this person with a 70% 10-year risk and you say to yourself, well, the statin medication alone, just taking a statin medication reduces the risk by 30%. You've then gone ahead and reduced their risk from 70% down to 40%. That's an extremely significant reduction. I know people want it to be zero, but that's just not going to happen. That said, that same person, if you go ahead and maximize all their risk factors, so they stop smoking, they lose weight, they exercise, they control their diabetes, they control their blood pressure, and you put them on a statin, you take that greater than 50% reduction in cardiovascular risk and you make it to about 6%. Now that is amazing, all right? But as again I'm mentioning, that's when you're modifying every single risk factor that we talked about, including the smoking, including the obesity, including the lack of activity. We're taking care of all of these things, all right? That's ideal risk factor modification, lowering that cardiovascular risk down to about 5% from above 50. That's tremendous. The statin is a part of that. But for the purpose of today's discussion, we're simply talking about the statin. We'll get to some of these other things in part 2 of the series. As I look at the clock here and see that there's only 7 minutes left, and I'm only on page 1 of my 3 pages of notes, I realize that we're going to be making part 2 and part 3 of this talk. But it's important because, again, cardiovascular disease is the #1 killer in America. 40% of people, of American adults, have high cholesterol. So this is not a moot point. This is not an irrelevant discussion. So let's go on to talk more about these intermediate. So I talked before. Those 2 people I talked about, one was a low-risk patient and one was a high-risk patient. The bulk of what I want to talk about is the intermediate risk patient. That's the patient with a cardiovascular risk of, let's say, or not let's say, between 5 and 10%. This is a lot of us out here. There's a lot of us. So I just drummed up a patient. It's a 50-year-old male. He does not have diabetes. Remember, if they have diabetes, they should automatically be on a statin. This patient is obese. This patient does not smoke. This patient has high blood pressure. This patient is inactive. And I chose these things very, very specifically because I wanted to get a patient that's very common. It's a 50-year-old male. I have many of those in my practice. No diabetes, and I specifically made the patient not diabetic because, remember, if a patient does have diabetes, they automatically should be on a statin. Keep that in mind for those of you who have diabetes and you're not on a statin. You should be on one. The patient is obese. Well, or overweight. 70% of Americans are overweight or obese. 70%. It's mind-boggling to me. Not a smoker. Has hypertension. All right. So, and let's include this patient has a family history of risk. So this patient is going to be on the high side of this, about 8.5% risk. So this patient who's intermediate risk for cardiovascular disease, in between 5 and 8%, 5 and 10%. Their risk is specifically, according to the calculator, 8.5% for their 10-year cardiovascular risk. This is a lot of people out there, and there's a lot of people out there who pose this question to themselves every day. Should I or should I not be on a statin? I've got many patients that go back and forth on this over the years. So I wanted to focus today's discussion and also next month's discussion, since I'm not going to finish it this month, on what to do about these people. Well, the first thing I do is I go into something we call shared decision making. And that is, I just give them the information. I'm like, listen, this is your risk of cardiovascular disease in the next 10 years is 8.5%. If you want to reduce that risk, the statin will lower your risk alone. The statin alone will lower your risk by 30%. The risk of side effects or complications from that medication, as I mentioned earlier, is very low. These medications are dirt cheap. Almost all of them are generic now, and literally you can buy them on GoodRx or one of the other discount pharmacies for pennies. So I just simply say, do you want to be on a statin? Here is the information. Do you want to be on the statin? And a lot of this has a lot to do with the patient's personality. There's 3 personality types in my practice. There's 3 patient personality types, and that is the patient number 1 who absolutely does not want to be on medicine unless absolutely necessary, and even then probably not. As an example, I have patients who are diabetic and have heart disease who refuse to take any medications, including statins. Some of these people, there's a subtype of this group of patient, and that is those patients who will take medications only after developing a heart problem. I've got quite a few of those. But that's subtype, that's type number 1. The second type of medication person is the person who wants to take a pill for everything. They want to take a pill for everything. And that is, doctor, I can't lose weight, I want a pill for that. Doctor, I can't smoke, I want a pill for that. Doctor, I want, I don't mean to be anyway giving you any kind of value judgment on that. I'm simply stating these are the types of patients that we deal with. This is how people are. And so they'd be very, very willing to take any kind of medication if it's going to improve their lifestyle. Better living through chemistry is what a lot of these folks say. And there's a lot of merit to some of these things they're saying. The patient in between is the more common patient, and that is the patient who is willing to take medication if that medication is going to benefit him or her based on my judgment. So when we pose the question to be or not to be on a statin, the first personality type is going to say absolutely not. They're just not even going to consider it no matter what evidence I present. The second personality type is going to take the statin based on the fact that it's going to be a 30% risk reduction for only taking that pill, better living through chemistry. The third patient, which again is by far the more common subtype of the patients I'm talking about, those are the patients you're going to have a really informed, in-depth discussion with and then go from there. So for the purposes of this discussion, we're going to assume that we're going to talk about that third subtype of patient, the patient who is willing to consider statins as a treatment for their high cholesterol. So just to summarize where we've been, because we're going to talk about this intermediate risk patient who's willing to consider the statin. That's going to be the bulk of our discussion for next program. Please tune in. But for those people who have the 3 definitive risks, the 3 hard and fast people who should be taking cholesterol medications are those with an LDL greater than 190, those people with diabetes, or those people with known cardiovascular disease. Again, next program, and I'm sure you can't wait, you're going to be telling your friends about it. We're going to be talking about the intermediate risk patient who's willing to consider a statin treatment. So thank you very much for tuning in today. I very much appreciate it. And whether you're tuning in on PEG TV, the PEG TV YouTube channel, or Your Health Matters with Dr. Peter Hogenkamp YouTube channel, please tell your friends about the program, especially today's program. It's so important, this high cholesterol epidemic that our country is in. We need to address it. Thanks again, and I look forward to seeing you next program. Cheers.